Welcome back. Our last topic for the immune system is going to be to look at some disorders, including autoimmunity, which is what we're kind of looking at here. Okay, so there's basically three ways that the immune response can be misguided. A hypersensitivity is a reaction to something that doesn't need to be reacted to, so the immune system is being overly sensitive. There is some overlap between hypersensitivity and autoimmunity, where we are reacting to a self antigen. And then we have immunodeficiencies, where the response is deficient in some way, shape, or form. So we're going to start with the hypersensitivities, and there are four types. We've got type 1, 2, 3, and 4. Type 1 is immediate. 2 and 3 are going to overlap with autoimmunity and are not going to be quite as acute. And then type 4 is delayed. So you can kind of come back to this and see this as we get into this. Okay, so type 1 is what is known as an acute. Generally, if somebody says they have allergies, this is the type of hypersensitivity they're talking about. These are all IgE mediated, which remember is a receptor on basophils and mast cells. When they degranulate, they are going to release histamine and other inflammatory and vasoactive, which in this case is vasodilating chemicals. These are what is known as anaphylactic reactions. This is a huge category. You have something as mild as hay fever, allergies to plants, molds, seasonal allergies, cat dander, things like that, all the way up to what could be potentially fatal reactions that lead to anaphylactic shock, such as bee sting allergies, peanut allergies, shellfish allergies. The major difference between the two ends of this is whether this response is happening in a local manner or if it's happening systemically. So let's take your just classic hay fever as an example. When you have hay fever, you breathe in the mold or whatever plant sex is floating around outside in the air, the pollen, and in your very local sinuses, you get degranulation of the mast cells, and that triggers a inflammatory response in your sinuses. So you get the increased blood flow, so you get vasodilation plus increased vascular permeability. So there's a lot of fluid moving into your sinuses. You get a lot of mucus. Okay, you're just basically dripping from everything on your face. Your eyes are itchy and they're dripping because of the histamine. Your nose is dripping. You've got postnasal drip. You're fairly miserable, but it's local. Let's say you have kind of a mild food allergy. What does it do? Causes a local response in the GI tract and likely gives you diarrhea. Again, not pleasant, but generally not fatal. On the opposite end of the continuum would be something like the peanut or the bee sting allergies, where it's not a local response, it's basophil related, and that's in your blood. So when your basophils degranulate systemically, you get a massive vasodilation, which tanks your blood pressure, and you go into anaphylactic shock. There is also generally closing of the throat that happens, so the airway becomes compromised. And this is a life-threatening situation. People who have severe type 1 hypersensitivities generally carry an EpiPen with them, which is a pre-filled syringe filled with epinephrine. And we know from studying blood pressure that epinephrine is a powerful vasoconstrictor. So we can administer the epi and get them to the hospital. You do not get to shoot yourself up with epinephrine and then think that you're okay, because that epinephrine will wear off, and in all likelihood, the allergen is still in your body and you're going to have a secondary response. You got to be at the hospital. Type 2 and 3 are called subacute and have significant overlap with autoimmunity. So type 2 is going to be either IgG or IgM mediated, and it's what's called a cytotoxic response. So cytotoxic means cells die. So we're going to see the death of cells. An example of this that isn't autoimmune related is the ABO blood transfusion reactions. So when your IgM clumps all of these red blood cells together, your macrophages are going to be stimulated to come in and eat them, and these cells are going to die. Therefore, it is a cytotoxic response. Any autoimmunity where you are actually killing the cells is going to fall into this category. So something like type 1 diabetes mellitus, where it's the destruction of the beta cells in the pancreas, Hashimoto's thyroiditis, where you destroy the thyroid. So any of the autoimmune conditions that are related to a cytotoxic response generally overlap with type 2. Type 3 is going to be, again, IgG or IgM mediated, but now it's going to be related to the deposition of immune complexes that drive inflammation and the destruction of tissues. So here, again, overlapping with autoimmunity, systemic lupus is kind of the poster child for type 3, where the immune complexes, instead of getting cleared out of your body, get lodged in your tissues, like the lining of a blood vessel or the lining of something, the epithelium. And an immune complex, the job of this complex is to drive the inflammatory response, but it should be a temporary structure. It should be processed out through your liver, but these don't get processed out, they get stuck. And so it drives constant inflammation that destroys the tissue. Rheumatoid arthritis is also an example of a type 3 hypersensitivity, where the immune complexes get lodged in the synovial membranes, particularly of the hands, and basically the inflammatory response destroys the joint completely. So there's a lot of tissue destruction that occurs in these type 3 hypersensitivities. Type 4 is the only one that is delayed. It can take up to 48 hours or so before you see a response. And type 4 is the only one that is not related to antibodies. So there's no antibody mediation here. It's all going to be macrophages and cytotoxic T cells. You can think of type 4 as skin related. So they occur on the surface of you. Poison ivy is a type 4 hypersensitivity. So we all know that if you are sensitive to poison ivy, you don't break out in the rash immediately. It takes a while for it to show up. Cosmetic allergies fall into this category. The TB skin tests that you guys are consistently taking to work in the healthcare field basically work off of this same principle. If you have memory to that tuberculin protein that they introduce directly under the skin, then you will have a memory response within a couple days, and that means that you have possibly been exposed to TB. Now, it's not a guarantee, don't freak out. But other things like the poison ivy or something like that, they enter through the skin, and we get the cytotoxic T cell and the macrophages that come in and are going to create the reaction at the skin. Nickel allergies also do this. So if you have a nickel allergy, a lot of times this happens when you're wearing earrings that have nickel in them, and you end up with this kind of oozing sore on your ear. So these are all skin related and tend to take a little bit of time to show up. Okay, so kind of similar, overlapping with type 2 and 3 are the autoimmune diseases. So this is where that motto that we started this whole chapter with is a little unclear. So we said that it's a pretty black and white statement. You're either with us or you're against us. This is the gray area in between where we're not sure. And it can be a something that tends to be fairly specific versus something that is very widespread. And so the symptoms and the treatments are all going to depend on which ones we're talking about. So we've got over 80 different diseases that are recognized as autoimmunity. So again, some of them are very specific. So rheumatoid arthritis, synovial membranes, myasthenia gravis, the acetylcholine receptor on skeletal muscles, multiple sclerosis, the myelin sheath, Hashimoto's thyroiditis, which you're actually seeing right here, the thyroid gland, type 1 diabetes mellitus, the beta cells of the pancreas, glomerulonephritis, the glomerulus in the kidney. And then you also have things like systemic lupus that are very widespread. So treatment depends on what is affected and how significantly it's affected. So, for example, something like Hashimoto's thyroiditis, it's in theory fairly simple to treat. You simply have to take thyroid hormone because your thyroid is being destroyed and not releasing the thyroid hormone. But it can take years to find the right combination of the right versions of thyroid hormone to get your body back to functioning normal metabolically. So while that's a simple pill, certain number of pills you have to take a day, it's, not quite as significant as something like systemic lupus, where you can destroy huge amounts of tissue. Something like that tends to go in flares, where you have a very significant reaction and then it tends to taper down. When we're in the middle of a flare, one of the only things we can do is try to dampen the entire immune system, often through the use of corticosteroids, which have their own set of problems, and you can't be on them forever, so you have to go on them and off them and on them and off them. There is some success with the newer biologics that are less damaging than the corticosteroids, but still are not without risk, in that the only way to really target some of these is to knock out the immune system completely. And that it targets the entire immune system. There's no way to pinpoint this one reaction that's causing the problem. And so it leaves you, mildly to severely immunocompromised when you're on them. So treatment really is not great. So even in something as simple as Hashimoto's, like I said, it could take years to figure out what combination works. And when you're dealing with something like lupus or RA, treatment is significant and there are significant side effects. So we're not really good at treating these. So then why does it happen? We don't have a 100% answer on this. We have a few different ideas. Let's talk about these two first, genetics and the environment. Our best hypothesis currently is that there is both a genetic predisposition and an environmental trigger needed to develop autoimmunity. In other words, you have to be born with a predisposition to this, but you also have to come in contact with an environmental trigger. Heavy metals, certain viruses like Epstein-Barr virus is a big one that triggers autoimmunity. You have to come in contact with something that triggers this response. So our best bet is that you've got a certain subset of the population that is genetically predisposed, and then once they run into that trigger that turns it on, what tends to happen is they collect numerous autoimmune diseases. So generally speaking, it seems as if that trigger turns it on, and then the immune system begins to lose hold of self versus non-self. So going along with this idea that there would need to be a genetic predisposition, let's talk about something like rheumatic fever. So one of the scenarios that this happens is you run into something where you have an antigen that is foreign that really closely resembles a self-antigen. So this can happen when somebody has strep throat. One of the reasons that we are so intent on treating strep throat is that there is a possibility of developing autoimmunity in the form of rheumatic fever when you've undergone a strep throat infection. So our goal is to treat it before your immune system ever sees it. So the problem in a certain subset of people who are predisposed to this is if they have strep throat, their body forms antibodies against the strep bacteria, but those antibodies can cross-react with structures of themselves, particularly their heart. And it leads to rheumatic fever, which can then lead to rheumatic heart disease. And so that's a pretty significant complication of a strep infection. We don't know who's genetically predisposed and who isn't. Therefore, we just try to treat strep throat aggressively. The other thing that we feel could certainly come into play here when it comes to autoimmunity is the generation of new self-antigens. All of the education process that occurs in your immune system, the education of the T cells, all of that happens during fetal development and early childhood. Remember that the thymus essentially disappears by adulthood. So there's no more education to be had. So if you go, through just random mutation, you develop a new antigen, there's no way to tell your immune system that this is self. That process has already happened. So we don't have a way to go back and kind of edit the list of things that we consider self. So this is a very active area of research because, again, these can have very significant effects to the patient, and we really are not good at treating them yet. Okay, so the last thing we're going to talk about is immunodeficiencies, and we're going to start with a congenital immunodeficiency, which means that this was genetically related and the issue present at birth. So there are multiple versions of this. I have chosen to look at the most severe, which is called SCID, Severe Combined Immunodeficiency Disease. These are genetic mutations that cause very little, if any, T cell and B cell development, which means that you basically don't have an immune system. So David Vetter, which you're looking at here, was one of the people that we learned a great deal about this disease from. So it was known that he would have this, so he was born into a protective enclosure and was never actually in contact with any other human being. Any contact came via the gloves. Okay, so without a functioning immune system, the air is pathogenic. So he spent his short life in a protective enclosure. He died when he was 12. He died following complications of a bone marrow transplant where they were trying to cure him. They took bone marrow from his sister, and this was, early 80s, so we didn't have the screening abilities we have now. And they screened it for all the major things, but they didn't screen it for every little minor thing, and they put it into him, and it turns out that she had a latent Epstein-Barr virus infection. So EBV is the virus that causes mononucleosis, which most children get. EBV is a herpes family virus, which means that it takes up residence in the body. It does not leave. And so she was not actively having mono, and they didn't test it for him. And they put this into him, and without having any immune system to keep this virus in check, one of the complications of Epstein-Barr is lymphoma. And so he ended up dying of lymphoma as a result of the transfer. So there are multiple versions of these congenital versions of immunodeficiency. This one is B and T cells. There are ones that are just B cells. There are ones that are just T cells. There are ones that are just phagocytes. There's ones that are just complement. So there's lots of versions of these that are leaving the person deficient in one or more aspects of their immune function from birth. The other version of immunodeficiency is an acquired version, where this is not genetic. Now, can you have HIV at birth? Yes, but it's not in your genes. The virus was passed from mother to child, and that's why it's still acquired compared to congenital. So the other version of this is an acquired immunodeficiency syndrome, which is AIDS. So human immunodeficiency virus is the virus which leads to AIDS. So if you're HIV positive, you're carrying the virus, and AIDS is a distinction that occurs at some point along the HIV infection when you have reached certain milestones in the infection in terms of the opportunistic infections and the T cell count. So in other words, there are a lot of HIV positive people who do not have AIDS. Will they progress to AIDS? As far as we know, probably, but treatment is working fairly well. So, you know, we're in kind of a area where, you know, we don't really have a cure or anything, but we're doing a lot better with it. And so we don't really know exactly if everyone will progress to AIDS. You know, we're starting to see, because of the treatments that have been available over the last several decades, we're starting to see people die from other things. You know, like they get to be 70 years old and they just have heart disease, and, you know, they die of heart disease instead of AIDS. So we have HIV positive patients that are now dying of just old age things. So that's actually good news, the fact that we've been able to prolong the HIV positive portion and decrease the number of people that are progressing to AIDS, at least in the short term. So the virus targets the helper T cells. So we talked about this. We said that the helper T was the gateway, and every aspect of the immune system relies on it. So if we knock this cell out, which HIV basically kills these cells, then we essentially remove all aspects of the immune system, aside from the first line, which isn't going to do that much without help. That is why it's so devastating. So transmission of HIV is going to occur through bodily fluids. So we're talking about semen, pre-ejaculate, vaginal secretions, blood, and breast milk. The most common methods would be unsafe sex practices, contaminated needle sharing, breastfeeding, and then mother to child during the delivery process. The early symptoms are not specific. They're flu-like. Within a month or two after infection, you might feel like you have the flu, which in all likelihood, if you feel like you have the flu, you're going to think you have the flu, not HIV. And that's one of the issues with this, is that there's no big red flashing light that says, hey, HIV, HIV. The early stages are very non-specific. So here what we're tracking is the viral load in red versus the T cell count in blue. So at the primary infection, T cells are high, viral load is low. Now, this is that sort of 2 months, 1 to 2 months post infection. You get a very high viral load and your T cells drop. This is the point where HIV is essentially seeding your body. It's moving around to all of the different lymphatic organs that you have. And then it basically goes into a clinical latency period. People don't progress quickly into symptoms after this state right here. And so the progression is kind of this fight where, quite frankly, your immune system wins. It holds the virus in check for years before you really begin to progress. And that is one of the sneakiest things about this virus, is that it keeps its host alive and in fairly good health for years before we begin to see the telltale signs of the disease, which means think of how much transmission can happen within years of latency. And that's really, when we look at this virus, it's smart. It targets the gateway cell. It allows the host to stay alive and transmit for decades. Now, here's where the question becomes, is everybody going to progress to this? I mean, clinically, as far as we know, we don't have a way to stop it, but like I said, some people are just dying of old age. But assuming that they would live long enough, what we know about the progression of the disease is that, yes, everyone will eventually progress to the late stages, where we begin to see the significant toll taken on the body here. This is kind of here where these symptoms show up, and you can see that these are not pleasant. We begin to really see a decline in the T cells, and we see the opportunistic infections and diseases show up, the different types of cancers and pneumonias and things like that, that a healthy, functioning individual could fight off. But in this severely immunocompromised state, we see these diseases just take hold of the patients. They get tuberculosis. There's just a ton of what are called opportunistic infections and diseases that show up. And eventually, as the viral load increases and the T cells drop to essentially zero, we will progress to death. So unfortunately, that is the pathway that we know of. Now, is everybody reaching that? No. Why are they reaching it? Because treatment has gotten better. So we have multiple antiretroviral drugs that target HIV at multiple points in the viral life cycle. We use them in a cocktail formation, so you've got multiple different drugs that you're on each time. You do have to monitor this, though, because your drug cocktail does need to be tweaked to make sure that it's still functioning. So we do constant monitoring of T cell counts, viral loads, and sort of making sure that the patient is still working well with their drug therapy. The drugs extend clinical latency. They extend the period in the middle. But the patient can still transmit if they have a viral load, and they do have to stay on the drugs. Once you come off the drugs that are suppressing the virus is still there. We don't have a way of getting it out. So if you stop taking the drugs, the viral load will go up and the T cells will go down. So, prevention, obviously, you can abstain from sexual activity, abstain from using any sort of, um, intravenous drugs, things like that. Abstain from the activities that would lead you to being exposed. If you're going to have sex, use condoms. So, latex based, um, not a animal skin type of condom. Those have pores big enough for HIV to pass through them. If you have a latex allergy, you got to go with the nitrile or um, the non-latex but not animal skin condoms. It's one of those every time, always used, and properly used, the right lubricants, things like that. You got to get tested regularly, and make sure that your partners are tested. Particularly if you're pregnant, we need to know if you have HIV, because one of the main ways that transmission occurs is through birth and then breastfeeding. So we need to know if you have HIV and are pregnant. You need to know if your partners, obviously. You getting tested does not necessarily mean that you have the same result as your partner does, because that's just not how things go. So you have to get tested and have your partner tested. Statistically, limiting your partners could decrease the likelihood that you would get exposed to HIV. That being said, you can have sex with one person and get exposed to every sexually transmitted infection. So this is a statistic for sure. If you are going to use IV drugs, don't share needles. There are needle exchange programs to try to make sure that everybody has a clean needle to use. So there are certainly ways to make it less likely that you would be exposed. Those of you working in the healthcare field, that is also a possible exposure, needle sticks and things like that. So learning to be very careful in the workplace will also be very important.